Next, we'll hear from Bob Master, who's the Chief Executive Officer of the Commonwealth Care Alliance, a nonprofit, prepaid Medicare and Medicaid-financed care system caring for thousands of Medicaid and dual-eligible elders and younger individuals with disabilities through multidisciplinary primary care in Massachusetts low-income communities. There you go.
Thank you. In only 7 minutes, I've got to describe Commonwealth Care Alliance, and you can see how difficult it is. I struggle with that every day. I'm going to do that. I'm going to talk a little bit about the populations that we've been caring for, our successes, some of our challenges, and then I'm going to put into a paradigm what are the care delivery transformation needs that we have, that we have for a variety of different populations, and that should get me to my 6 slides in 7 minutes. So Commonwealth Care Alliance is if I can do I'm not certified, there it is, audio. What are we? We were created by Massachusetts advocacy community and like-minded clinicians. We're a nonprofit entity that I guess in the eyes of Medicare is a fully integrated dual-eligible special needs plan offering the whole range of Medicare and Medicaid benefits to an enrolled population for which we are fully at risk. There's a far better word. There was no language to describe what we were and why we're doing this many years ago. We have that language thanks to the ACA today. We're really probably a specialized population-based ACO that's a lot more coherent than the other ACOs, but we're doing not just medical and hospital, but long-term care, behavioral health. It's all in. What's the premise and why did the advocacy community come together with clinicians over decades, 3 decades, to create this? It was a sense that the healthcare world and the integration of supports and the promotion of autonomy and what we heard all morning, person-centered care, was not happening in the typical fee-for-service care finance system or the care delivery system. And the mission, simply stated, is to try to demonstrate at scale what is happening. And you heard from Lisa Iazzoni this morning. Lisa is not only on our board, but she is a board member of Boston Center for Independent Living, one of our advocacy organizations that I report to. There's 2 others as well. So basically, let me fast forward to where we are today. We were incorporated in 2003 and have grown from an organization of 10 employees to 750 employees, from hustling to raise $2 million to get capitalized to now managing over $750 million of Medicare and Medicaid premium. And we care for 2 populations. One was the first duals demonstration that informed the current demonstration, and that is senior care options. And today we have 6,800 enrollees, low-income seniors. What distinguishes us from others by design is that 75% of our seniors meet Medicaid's nursing home certifiability criteria with long-term services and support needs. And we'll explain how we do that. Some of the other data there tells you that we're in communities of color, most of the low-income communities. Our network is 45 primary care practices, but the enhancement really is, last year, $29 million above and beyond what Medicare would have paid into primary care interdisciplinary teams, nurses, nurse practitioners, social workers, and others, and behavioral health integrated into primary care. So having been in this business for a long time of how do we turn typical primary care into robust interdisciplinary care with a lot more investment, and do this not in one site as part of a demonstration, but in the real world across 45 sites, I can tell you it's messy. It is messy, and there is what we call a paradigm of transformation. Everything, a fully transformed system to a population-based care model has nurse practitioners, nurses, social workers working in a horizontal relationship with physicians, with shared decision-making, individualized care plans. Down at the first spectrum, when we start to do this work, you may find a lot of physicians that are still practicing the way we were all trained many years ago, that if I didn't see it, it didn't happen, and I got to see everything, do everything, and be everything to everybody else, and everything else along that spectrum of transformation takes place. And I'll give you some of the history and some of what we've done in that program over many, many years. Most recently, we're really very proud to say that Massachusetts, once again, is this national leader in the financing alignment demonstrations in OneCare. We're proud to say that we're the largest contractor in the Massachusetts demonstration. And since October 2013, have enrolled 10,000 younger individuals, dual eligible individuals with complex array of conditions, from serious mental illness, physical disabilities, developmental disabilities, and just so many social challenges that I thought as a clinician I had seen it all, and I came to realize that I hadn't. And I'll talk a little bit about that program as well. Taken together, it's about $750 million of premium, and people who know me know that I can't balance a checkbook, so it's totally shocking to me that this can happen. One thing I will say, let me see if I can, I'm having a little, so I want to go through the redesign elements, but one of the things I will say in the previous slide, for the seniors, Medicare has done a great job over 5 decades in bonding seniors to practices, community health centers, safety net, regular practices. Where things went off the rails for seniors is when people became impaired, had disability, increasing disability, cognitive, physical impairments. Literally, the physician was signing VNA forms or getting notes from emergency rooms, was no longer in a model that could meet needs, and thus the interdisciplinary teams to support that. For the OneCare population, we use the same model for those that are bonded, but here you have populations that have never been and will likely never be effectively bonded to a primary care practice. People with very severe persistent mental illness, intermittent homelessness, concurrent substance abuse. Data that we have in Massachusetts is do not keep appointment rates in primary care of 60 to 70%. Do not keep appointment rates with psychiatry of 60 to 70%. Floating free in the system, you have to create new structures. And I believe if it's happening in Massachusetts, it's probably happening everywhere like that. So what are the redesign elements? Very, very fast. Primary care interdisciplinary teams with professional, I'll let you see this, but essentially it's teams integrated into care for people with involved physical disabilities. You're basically going to have very, very intensive teams, say a nurse practitioner with a caseload of 1 to 40, a primary care physician with 6 nurse practitioners, 1 to 300. You need an elastic response for new problems. That is absent in the American healthcare system today. These are people with low thresholds to complications. This morning you heard a lot about the need to think about durable medical equipment as a clinical service and not as a benefit to be managed, integration of behavioral health, and you need a web-based EMR system to tie that all together since this is in communities. There's another element to what we call, we've learned that you would think would be enough to do the transformation, but it isn't. And this really, I think, resonates with what I also heard this morning. We find that we absolutely needed to extend primary care into the hospital where we have enough volume, and we have sufficient volume in 3 hospitals in Massachusetts. You have to have about 12 inpatients at any one time. What was said, the hospitalist model, that it essentially revolutionized inpatient care in Massachusetts between 2007 and 2008. And we saw readmission rates go through the roof. We saw an unbelievable discontinuity, advanced care planning essentially in tatters. And we essentially had to put our own primary care teams in hospitals, and there's a redesigned hospitalist model. So this is what we call primary care white space, because primary care has to be there and can't abdicate that to a hospital. Similarly, in the mental health side, we found that there was an absence of residential community-based crisis stabilization units instead of psych hospitals. And we found that we had to create those as well to fill the white space. And similarly, if we're managing a lot of people of all ages near the end of life, that you need to think about palliative care, a consultation and education service for primary care. It's really beyond the ability of typical primary care to do that, and then you've got to elaborate that in the community. So this is not just building the teams into the practices, but then you've got to support the practices like that. 2 more slides. This is the slide that essentially says how we're doing, and most of our experience really comes from 11 years in our senior program. And by and large, there's no way we could make these investments into primary care, care coordination in communities, and a lot of long-term care services if we didn't have, get the result of significant reductions of hospitalizations and nursing home placements. And when compared to an adjusted, risk score adjusted, a dual fee for service, our hospitalization admissions and days are 52%. That's been constant forever. Nursing home placements down by 66% in external studies. That's essentially how it's paying for itself. So by the way, what's our test for statistical significance? We're financially still here at the end of the year. That we make all of these investments and the reductions in hospitalizations and nursing home placements more than offset that. The one thing I do want to say about OneCare, which is an extraordinary challenge for us, but a challenge that we are wrestling to the ground. It's taking long. First of all, it is an absolute privilege to be involved in a national effort that is making such a value statement, that the most marginalized people among us that have been really shuttled off for decades or longer into segregated institutions, that we are actually trying to equalize, provide equity in care, and that is a remarkable statement. So yes, it's a cost issue because the costs are overwhelming. The care issues are absolutely challenging. This is the final frontier of these populations. I can say this, and we're challenged like everyone else in this, but we've made movement over the first 18 months. I wish I could say toward profitability or toward break even, not quite there, but we're on a path over the next year and a half to get there in terms of new models of care and understanding how best to engage these populations. And I'll have more to say about that later, and I have a summary, but done. Take it.